Yeah, we're right on time. Good morning, everybody. All right, good morning. I know it's a little bit early on Friday morning, but thank you for being here. It's going to be a great panel. My name is Raul Ayala. I am not Eileen Loringer, who is going to be your moderator today. She's over at the American Academy of Periodontology. She's an executive director of one of their divisions, and they're having a trustee meeting, so they pulled rank on her, and she's there, and you got me. I am a deputy federal public defender. I have a little bit of work experience with opioids, but these four gentlemen here will fill you in on the topic. I'm just going to try to keep the ball rolling, so to speak. But the title for today's topic is Opioids in America, a multidisciplinary discussion on cause, effect, and solutions. We have four very distinguished speakers this morning. I'm going to introduce them briefly, and then we'll get started. To my immediate right is Dr. Nirav Shah, who's both a doctor and a JD. Dr. Shah is currently the director of the Illinois Department of Public Health. He's also an attorney and former public health economist, worked with various organizations around the world on cost-effective health systems and methods to enhance the delivery of efficient health care in policy and practice. He's a native Chicagoan. He's worked, he got both his medical and his law degrees from the University of Chicago. Worked in Phnom Penh, Cambodia, where he helped address some of their public health issues. He thereafter worked as an attorney at the law firm Sidley in Austin, where he focused on administrative and legal aspects of healthcare and public health. Welcome, Dr. Shah.
Thank you.
To his right is Dr. David Preble, who's the Senior Vice President of the American Dental Association Practice Institute, where they provide strategic vision and leadership to help develop ADA policy around practice issues that impact dental professional members, their patients, and the public at large. Before that, Dr. Preble has held previous positions with the ADA, including Director of the Council on Dental Benefit Programs and Director of the Commission on Dental Accreditation. He's a graduate of Georgetown University Dental School, and about 15 years later graduated from St. Thomas University School of Law in Miami. He's also gained distinction as a certified association executive from the American Society of Association Executives, and earned a certificate of professional achievement in nonprofit management from the Kellogg School of Management at Northwestern University here in Chicago. To my immediate left is Mr. Kirk. Mr. Kirk currently is the Corporate Affairs Manager at ComEd, the electrical utility here in northern Illinois, as their governmental relations and external affairs manager. Before that, he was the first assistant state attorney for here at Cook County for many years, where he helped manage an office, one of the largest in the country, 800 assistant state attorneys, 500 administrative staff, 100 sworn police officers. They handled over 34,000 felonies, 200,000 misdemeanors and traffic offenses in his office. Before that, he was chief of staff to that office. Before that, he was a partner at Query and Harrow here in Chicago. He worked also as what we call a line trial attorney with the state attorney's office for several years, trying cases in the Child Support Enforcement Division, the Juvenile Justice Bureau, the Narcotics and Prosecutions Bureau, and Criminal Prosecutions Bureau, so he's basically done it all. He's also received a number of distinguished awards or recognition from the Chicago Bar Association, where he's been part of their board, part of the Judicial Evaluations Committee. He's gained also some notoriety here locally through the Chicago Bar Foundation for his civic engagement and philanthropic interests. And last but certainly not least, I know I have you here, Doctor. Dr. Davidson. There we go. Dr. Davidson, also a a medical doctor, a board-certified physician and anesthesiologist, a medical director of pain services for North Shore Health Systems. Prior to that, he was at the University of Chicago, ran their pain stewardship program and directed inpatient pain services. He is the liaison from the American Society of Anesthesiologists to the Pain Care Coalition, and has been a pain consultant to other organizations and also with some educational video work. Clinical practice is spent directing several hospitals' pain clinics and 3 separate pain services while practicing pain medicine most days of the week in outpatient and inpatient settings. So please join me in welcoming our 4 distinguished panelists. And why don't we start with Dr. Shaw, please.
Okay, great. Good morning, everyone. Let's see here. Yeah, we're good. Well, thank you all for inviting. Thanks to the American Bar Association for having me here. It's good to be back in a room full of lawyers. How many times do you think that sentence is said on a monthly or weekly basis in the United States? But I do miss being back with my colleagues in law. As Raul mentioned, I'm a lapsed attorney, so I'm glad to be back. And thanks to my colleagues here for joining. I have been tasked with setting the table a little bit, or just kind of setting the stage with respect to where we are with the opioid crisis. And in keeping with the title of this panel, Causes, Effects, and Solutions, I'd like to just touch on each of those very briefly. I'm hoping not to speak for more than about 7 or 8 minutes. Wow.
Shed some light on the subject.
Yeah, well, I should have shaved or something if I'd known the lights were going to be that bright. So I'm hoping not to spend too much time and really allow my colleagues to fill in many of the gaps. So let's start with causes. The opioid crisis, as we know it, has really manifest, or is the product of many multifaceted elements that were left to fester for many years. Like many multifaceted problems, it wasn't just one thing. It was, in fact, a perfect storm of separate perfect storms that all seemed to merge or coalesce around the same time to lead us to the crisis that we're dealing with now. In the interest of time, I'm just going to spotlight 2 or 3 of those, and then perhaps we can elaborate upon them during discussion. Let's start in no particular order with doctors themselves. When I was in medical school many years ago, the mantra was zero pain. Every single patient had to reach a level of zero pain. And I distinctly remember, in fact, the chief of surgery where I went to medical school, educating medical students on the fact that if patients who are coming out of surgery weren't brought to a level of zero pain, they wouldn't ambulate. They wouldn't get out of bed quickly enough, and that could cause infections. They wouldn't have enough they wouldn't have enough pain suppression in order to allow them to cough, which could lead them to get pneumonia, for example. So the educational model at that time was very much focused on getting folks to zero pain. And as a result of that, opioids were a very readily available solution. They were easy to use. They were off the shelf. And for the most part, so we were told at the time, the side effects, particularly those involving the potential for longer-term addiction, were minimal. We now know today that was not the case. But the medical community was very much a fan of this, both in the inpatient setting as well as in the outpatient setting. Many of you yourselves have perhaps struggled with issues like lower back pain. Very difficult for most internal medicine or office-based physicians to deal with problems like lower back pain. But then lo and behold, along came solutions like the opioids, particularly longer-acting ones, and those were like magic for a lot of patients as well as physicians. So physicians certainly were one of the various storms that were brewing that led us eventually to where we are. But if it were just the medical community, we wouldn't be where we are today. Part and parcel with the medical community were government reimbursement programs involving the reimbursement programs that I myself now oversee. At the time, and I'm referring to not just Medicare and Medicaid, but a whole host of other reimbursement programs, some of which existed in the private markets as well. And around this same time, one of the mantras that insurers or reimbursers like governments were pushing was very much a system whereby physicians were rated. We still have that to some degree, but back then, one of the key axes upon which physicians were rated were their abilities to manage pain. Patients were given surveys. They were asked in the hospital whether their pain was being adequately managed. If anyone who spent time in a hospital in the late 90s or 2000s perhaps remembers the pain scale on the wall, the Mr. Yuck and skull and crossbones and nuclear fallout. I mean, it was all manners of things. And doctors were very much graded and thus reimbursed upon their ability to manage that pain. One of the mantras in healthcare back then as well as today is that if you want doctors to change their behavior, change how you pay them. And when you grade individuals on their ability to manage pain and get that pain to zero, and then you tether payment to that, you can almost be assured that you're going to have an onslaught of prescribing. And of course, that's eventually what we saw, were radically high levels of prescribing of opioids. But if it had just been physicians, if it had just been reimbursement structures, we probably still wouldn't have the crisis that we're dealing with today. A third element of that crisis, and perhaps everyone's favorite bugaboo, are the pharmaceutical companies themselves. Much has been written about the pharmaceutical companies, much has been litigated already about the pharmaceutical companies, and much is currently being litigated about them. I won't comment on any of the current litigation or indeed any of the past litigation. All I will say is that one of the open questions to this day is the extent to which pharmaceutical companies were leading the demand curve or following it. Certainly, we now know, based on litigation that occurred and was taken at the appellate level in the D.C. Circuit, that there was a high degree of misbranding under the Federal Food, Drug, and Cosmetic Act on the part of Purdue Pharmaceuticals. So we do know that there was misbranding, no question about that. But to what extent were the pharmaceutical companies also responding to market pressures and market demand? Keep in mind that and my anesthesia colleagues can elaborate on this more, keep in mind that probably for the better part of 100 years, to this day, one of the holy grails of modern medicine is an analgesic, a pain pill that exists but that does not lead to longer-term addiction. And at the time, many of the pharmaceutical companies, including Purdue Pharmaceuticals, had it in their mind that they had stumbled upon that. They had stumbled upon a long-acting form of a opioid called oxycodone, and they were able to put a coating around it that led to a continuous release. It didn't lead to the spikes and troughs that had previously existed. It led to a continuous release of oxycodone, and thus was born the drug OxyContin, a continuous release of oxycodone. In their mind, they had stumbled upon a medical miracle, and the extent to which they were operating on science versus purely driven by nefarious motives, that has yet to be decided, although there has already been a lot of litigation to that effect. So that's just a flavor for some of the factors that led us into the current crisis. The medical community itself, the reimbursement systems, pharmaceutical companies. Now, depending on who you talk to, everyone's got one that they like to spotlight, but the truth of the matter is that it was very multifaceted. And as a result of that, it's going to take a multifaceted approach to get us out of the opioid crisis. So let's turn to what's going on and what we see as some of the solutions. In terms of the effects, in 2016 in the United States, there were over 60,000 drug-related deaths. 60,000 drug-related deaths, and about 2/3 of those, 40,000 drug-related, or of those 40,000 were due to opioids. I mean, 40,000 deaths. In Illinois alone, we had over 2,000 deaths just last year alone related to the opioid crisis. And the truth of the matter is that those numbers, no matter how staggering you may perceive them, don't even begin to capture the full scope of the crisis. Those are mortality numbers, but the morbidity associated with the opioid crisis is staggering. Time off from work, lost wages, etc. And that doesn't even begin to capture it. To me, the real damage of the opioid crisis is not exactly rooted in the number of deaths or the number of days off of work. It's the stigma that we see associated with it. And what I will tell everyone in this room is that about 2.5 years ago, I was down south, and my team and I were in Effingham, Illinois, a small town in southern Illinois, and we were listening to a woman speak who had lost her son because of a heroin overdose. And what she relayed is a message that I've heard repeatedly now. And it was about the stigma associated with the opioid crisis. And her message was one that has haunted me ever since, which is that when you live in a small town in southern Illinois and your kid dies of leukemia, every single person in town shows up for the funeral. Everyone will bring you a casserole and they will stay at your house for days and days on end. But when you live in southern Illinois and your 17-year-old kid dies under a bridge with a heroin needle in his arm, no one shows up. No one comes to the funeral. No one brings you any casseroles. And it's that stigma that we have just now begun to really grapple with that is the real crushing aspect of the opioid crisis. For me, I see a stark number of parallels between the opioid crisis as we have it today and the HIV crisis. I'm fond of saying that the opioid crisis is this generation's HIV crisis. Both in terms of the number of deaths are eerily similar, but in particular because of the stigma associated with it. And as a side note, the stigma issue is very difficult to crack. I'm going to talk about some solutions, regulatory and otherwise, in a minute, and those are easy compared with turning around the stigma. For me, in my lifetime, the thing that really turned the page on the stigma associated with HIV was when Magic Johnson came out as having HIV. And that all of a sudden switched the discussion almost entirely. Almost overnight, it was something that people would and should talk about. We haven't reached that yet with the opioid crisis, and if anyone has ideas on how to, there's a Nobel Prize waiting for you. But let's talk about some of the solutions. There are a number of initiatives going on at the national and state level with respect to trying to get our head around the opioid crisis. But one thing I would urge everyone to think about is when we talk about the opioid crisis, or when it is talked about, it's often with a very broad brush. The fact of the matter is the opioid crisis today is radically different, well, not radically, is different from what it was 18 months ago and much different from what it was 2 or 3 years ago. 2, 3, 4 years ago, what we were primarily dealing with was a crisis involving opioid overprescribing. That gave way to a crisis largely focused on heroin. But what we are dealing with, at least in Illinois right now, is not really an overprescribing crisis. It's not even entirely a heroin crisis. It's primarily a fentanyl crisis. I use fentanyl as a shorthand for other synthetic drugs that are cut into heroin that are resoundingly deadly. In the past 18 months in Illinois, 22 months now in Illinois, the number of deaths attributable to fentanyl and its cousins has gone from 83 to 916. So an over 10-fold increase in about 20 months simply because of these fentanyl analogs. So we're really dealing with multiple crises that are ebbing and flowing at the same time. There are some solutions that we have implemented that I believe are starting to show promise. The first is a rule that our agency put into place not too long ago to require physicians to check the PMP. The PMP is the Prescription Monitoring Program. It's a database of every dispensation of an opioid in the state of Illinois. And it allows physicians to spot behavior amongst patients that might be signals for addictive or drug-seeking potential, and thus cut them off or not start them in the first instance. That has started to show benefit. For the first time last year in Illinois, I'm just checking my time, for the first time last year in Illinois, the number of opioids prescribed in the state started to turn downward. Now, it's still about 8-fold higher than what it was in 2001, but every positive step is our motto at the agency. There are other strategies and solutions on the horizon that we are in the process of implementing. Or another one that we've already implemented, I'm trying to keep it more regulatory focused given the audience. Another one that we implemented back in October of last year was a statewide standing order. This was an order issued by our chief medical officer at the department, not me because I'm not a real doctor. And that was, as my father is fond of pointing out, that was an order that allowed every single person in the state of Illinois to go to a pharmacy and purchase the drug overdose reversal drug naloxone. It was essentially a prescription for everybody in the state. And that has, as a result, led to a dramatic increase, thankfully, in the number of naloxone injectors that are being sold or dispensed by pharmacies. The third thing that I want to just highlight really quickly is something that we are in the process of rolling out. And it's not strictly regulatory, it's more in the vein of behavioral economics. But it taps into the notion that physicians are intensely competitive. One way to change physician behavior is to change how you pay them. Fine, got it. But another, and that's very much a stick approach, but carrots are generally better than sticks. So one of the things that we are rolling out is something where we've tapped into physicians' inherent competitiveness. And we are in the process of rolling out and sending out letters to doctors in Illinois, essentially saying to the doctor, Dr. Jones, you practice medicine how you see fit, but just so you know, here's how your opioid prescribing stacks up with other doctors in your area. You do what you need to do, but we just want you to know that your opioid prescribing is way higher than everybody else's. That's your call, but if you feel like you want to change that and do better than your peers, then feel free to do so. No money is involved. We don't have to change the complicated reimbursement rules or anything of that sort. I'll get your question in just a second. And it taps into this notion that doctors are always trying to compete with each other. Of course, there are downsides. Oncologists, pain management physicians, like my colleague here, will take that letter and laugh at it and chuck it out. That's fine. That's okay. But for a family practitioner or someone of that sort, they may see that and say, wow, I had no idea, and I want to be better than those other folks. I'm going to change. So with that, I will turn it over back to the moderator. Oh, actually, happy to take your question, or if you'd rather wait.
Well, can we wait? We'll have some time at the end for questions and answers, so please write them down. So I'll turn now to Dr. Dickerson, please.
Sure.
There.
So, in similar vein to Dr. Shah, first I'd just like to say thank you everyone for taking the time to join us for this conversation. Hopefully we're going to have a nice broad optic by the end and be able to sort of understand what's happening all the way from the front lines all the way up to regulatory and even in the special sectors. I really look at this as a problem that faces three specific silos. There's the patient care silo where I spend a lot of my time, but I cross over into the other two, which is really industrial and legislative. And each of those silos has their own ideas as to how we can curb the opioid epidemic. And as Dr. Shah pointed out, we all have our favorite talking points. And our optics sometimes limit us to being able to have the viewpoint of what those other silos might think of what we're doing. And so it's really powerful to see all of the collaborations that are coming out of the opioid epidemic. And there's some promise there in terms of the public-private partnerships that are bringing those silos together to make sure that we're thinking about this in a broad optic that doesn't create unintended consequences for patients, providers, health systems, and even the people that are trying to develop better products for us to treat pain with. That's a real challenge. And some of the issues in this for clinicians that are advocates for their patients, advocates for their practice, we have to recognize sort of what are the intrinsic issues with pain care in this country. And I'll refer you to a document that came out of the Institute of Medicine's 2011 Living with Pain in America. One of the suggestions was that there should be a national pain strategy. And the national pain strategy was created to effectively leverage what we currently understand about the opioid epidemic and the chronic pain epidemic, since it affects 1 in 5 adults in this country, and making sure that we're thinking broadly, again, across disciplines, to address this with additional research. That document is a good background. It's, I consider, a core curriculum for people that are practicing pain medicine, which is effectively every doctor, even dermatologists, are seeing patients with painful skin conditions and being faced with what's the best course of action. The broadest challenge is moving away from this idea that pain equals pain medicine. That's the medicine that we typically think of are prototypically opioids, which have diminishing returns over time. For acute pain, they're considered a gold standard. However, when does acute pain abate? When does it become subacute pain? When does it become chronic pain? We quickly dive into nuance, and we recognize over the time scale of asking those questions, those opioids are actively changing their therapeutic window. And the therapeutic window is an interesting concept for looking at drugs. We like to think that that's static, that it doesn't change over time, but with opioids it does. And the therapeutic window is effectively the amount of buffer I have in between getting the effect that I want and starting to have side effects that couple with that. And over time, we see that that therapeutic window, almost universally, for the majority of patients, narrows. and patients start to have side effects that our best intentions of treating their pain to enable their function is actually being impaired by the very thing that we're using to enable their function, because now they have new side effects: respiratory depression, sedation, itching, tolerance, and something even called hyperalgesia, where the opioids start to have a paradoxical effect. I use the example of I can make just about any patient diabetic by giving them insulin. Their pancreas stops producing insulin. Opioids, exogenously or prescribed by Dr. Dickerson, can have a similar effect on the body and mind, and can make it so that the body's nervous system and neuropsychiatric system becomes dependent and stops producing its own endogenous or natural pain-tolerating substances. That's a really unfortunate part of an analgesic or a prototypically holy grail. And so the time scale is important. And along those lines, we don't have a taxonomy for acute pain, meaning all acute pain is acute pain, but is acute dental pain different from trauma versus surgery? Is acute pain different in trauma versus surgery in a patient who has a seizure disorder or migraines? So effectively that it gets very nuanced as well there in terms of taxonomy. And there are some, the FDA does have a private-public partnership looking to develop a taxonomy for acute pain, which will be very helpful, because then we start moving away from acute pain equals pain medicine. We say, which acute pain? Sickle cell flare, that's acute pain in the setting of someone who might have chronic pain. A very different type of treatment probably is necessitated, as well as a different type of provider in that instance. So this oversimplification of a chronic, or of a very complex phenomenon as pain management, is probably at the crux of some of our unintended consequences as prescribers. Another major issue is, as we start to change, as we gamify or create competition in terms of being better doctors and prescribing less, we have to ask, are we coupling that with better access to substance use disorder treatment and to the type of care that I can provide from a non-opioid, non-pharmacologic standpoint? Expert consultation, whether it's for addiction or for persistent chronic pain, that access doesn't appear to be bolstering. It actually appears to be also diminishing, as there is this flood to our clinics to be able to provide that treatment as people are getting, quote unquote, cut off from their scripts. Doctors read the law, these letters, very differently, and they hear the law's changed. I can't do this anymore. And that's not what's changing. It's just that it's going to be a little more cumbersome for you to continue to provide that therapy for your patients. And also, you're going to have to be able to say, this is the specific pain diagnosis for my patient. So when we look at many multi-specialty guidelines, we recognize that it all comes back to, no longer can you just call it pain. What's causing the pain? And here's the real rub. Pain can be a symptom of a disease, or pain can be the disease itself. My gosh, what a challenge. Very quickly, even as a non-physician, you might say, I want nothing to do with that. And so those patients are hearing that at the point of care from their doctors they've known for a very long time. It's fracturing relationships that affects how perhaps their diabetes and hypertension are going to be managed, because those doctors are saying, we're not the clinic for you anymore. You need to go see Dr. Dickerson. And then they come see me, and I say, oh my gosh, I'm already managing X number of patients on opioid therapy. And I just met you. So I go through all of these tests to figure out whether or not they're appropriate. I make sure that I have a pain diagnosis for them. And for a lot of these patients, that's a real time sink for my clinic, but we do it. It's a challenge, but we don't have the bandwidth to do it for every patient that's being sent from every family medicine and primary care clinic. And so controlling that message is going to be very important, because doctors are dumping. They're doing it. And they're doing it to effectively get off the letter list. They're doing it to satisfy their superiors that are also being told that your docs are on the letter list. So these are powerful tools for changing behavior, and I do think we prescribe far too many opioids in a non-expert fashion. But we have to ask ourselves, how are we also enabling, how are we not squeezing the balloon or kicking the can? Are those patients in the last 22 months the ones that are out perhaps trying heroin because it's cheaper, and the heroin dealer is not going to tell them, I'm not that kind of doctor? So these are the real challenges we face as pain medicine specialists. And I think that we have to take all of that in stride. The good news is everyone knows what's going on right now. And I say everyone as people who are in this bubble. Unfortunately, there are people outside of the bubble that practice medicine every day that don't put their hand up when I ask if they've heard a lecture on opioid safety in the past year or 3 years. And so there is a vacuum that's there, and there's a lot of fear behind it. And I hope that we continue these partnerships to continue that diffusion of best practice, so it couples with legislative change and development in the industrial space, so that we can actually all work together to really solve this and not create the next generation's problem.
Thank you, Doctor. Let's hear from Dr. Preble and the dental.
Dentists deal with is short duration acute pain. And this has not been the kind of pain that most of the studies and most of the guidelines from the CDC or anything. So it's just been whatever you're taught in school, and that has been carrying forward. And as Dr. Dickerson said, the gold standard for acute pain for many, many years was some sort of an opioid. But what we've found is that both the pharmacology and the evidence is clear that for this short duration acute post-surgical or dental pain, opioids are not even the first drug of choice. So we're educating the profession very aggressively about this, because the evidence is clear that you're going to actually get as good or better pain relief with a non-opioid. And in those cases where the pain has a pathway that responds best to an opioid, it can be a very, very low dose of an opioid for a very short duration, coupled with a larger dose of a non-opioid medication. So that's where we are now, getting that education out to a profession that kind of grew up with this idea that you prescribe an opioid is something that we're doing right now, but it's obvious to us from the reaction we're getting from the profession that it's not as bad a challenge as we expected it to be. The profession is starting to embrace this, and we're going to be monitoring the prescribing behavior of dentists, and we expect within the next couple of years to have the prescribing behavior about opioids to be dramatically reduced. But that's not the only part of this issue either. There is also this side of this that you have medical providers, whether it's physicians or dentists, who go into a profession with this empathy for patients. They want to relieve their pain. And we have patients who have been taught really to expect that even a low level of post-operative pain is not what's acceptable. It's not only the absence of pain, but potentially even a euphoric absence of pain. Mm-hmm. And that is more of a changing society kind of a thing that doctors have to have a role in to manage patients' expectations. That at some point as a society, we have to be able to say a level of pain that allows you to continue to have normal life, but it's not completely gone at all. That may be a better outcome than this euphoric, complete absence of pain. So we're working on that too. And that gets into this whole idea that dentists also have to be more cognizant of checking the PDMPs that Dr. Shaw talked about, the prescription drug monitoring programs. We're working regulatory and legislatively to make sure that those PDMPs are really doing the job, because they're not equal across the 50 states. Some of them are very, very effective and some are not. We're trying to get that so we get more information into the hands of the prescribers so they can learn to identify those patients who may be at risk for addictive behavior before they ever prescribe anything. And dentistry is also sensitive to the role that we have and have had about being the first impression of an opioid to adolescents in the removal of wisdom teeth. And with this evidence that it's not even the first drug of choice, even in those situations, and if so, very, very low doses, we expect to be able to get that under control too, because having an impressionable young person get their first taste, so to speak, of an opioid is not necessarily the right thing for the profession to do, even though they're going to have a certain low level of post-operative pain with non-opioids. But again, I don't want you to think that dentists are going down the road where we just don't care about patients' pain anymore. It's just honestly that there are better ways to do it. There are these combinations of different like for instance, ibuprofen works on a certain pathway, Advil, and your acetaminophen, which Tylenol works on another pathway. And when you combine those together, it becomes a very effective pain medication. But it's usually at prescription doses. You know, you're not going to just take your normal Advil. You take 800 milligrams, and I'm not going to get too technical with you. I'm just saying that there are really other ways to deal with this pain, and it doesn't have to be opioids. And that's what we're trying to get to, while still grappling with this quandary of doctors wanting to completely eliminate pain and patients having an expectation where that pain will be completely eliminated. And that's what we're up against.
Thank you, Doctor. Mr. Kirk? Sure.
So I come at this from a totally different perspective. My first observation as I sit up here is I am certain that this is the first time I've sat on a panel of all the panels I've sat on with being the sole lawyer amongst all doctors. And I feel a little bit at home too, because while I've spent the majority of my legal career as a practicing trial lawyer and the majority of that as a prosecutor, I'm no longer in the typical practice of law, or at least not for the moment. And so I feel at home, since Dr. Shaw is also a recovering lawyer as well. I come at it from a different perspective because one observation that you may make that I've made listening to my fellow panelists is that they often see people who are eventually going to be involved in the opioid crisis as a victim of it come in at the entry point. And as a prosecutor, you see the end result of it. If they're the carburetor, I'm the muffler as a prosecutor. So we see it after it's progressed and it's gone very far, and there's justice system involvement with the individuals. I started as a prosecutor back in the 90s, and one of my first assignments was in narcotics. And I can tell you that on a daily basis, I'd walk into court at 26 in California, the main criminal courthouse here in Chicago, and I'd get my call list that was, at least a page, if not 2 pages long, of the cases that were on the call that day. And they were all 0.1 grams of cocaine, 0.2 grams of heroin, some marijuana, this and that. And it was just, it was almost like a conveyor belt processing line. And you did that day in and day out. And as a young prosecutor, because you weren't a policymaker, you didn't really have to put much thought into it. Your job was to get through that call for the day and execute the law as it pertained to those cases. Your responsibility increases as you take on greater leadership roles in an organization. And although I started as a rank and file line prosecutor in the Cook County State's Attorney's Office, ultimately at the end of my career, I was the chief of staff and then the first assistant, which made me the number 2 person. And so you had the burden of starting to think about these things a little bit differently. And I'll never forget one day when I was first assistant, I woke up at 4 o'clock in the morning, as I often did, thinking about whatever the problem was going to be that day. And for whatever reason, when I woke up that day, it occurred to me that the way that we prosecute narcotics offenses was wrong, and that we needed to take a different look at it. And for a number of different drivers, in part because of the economic expense of prosecuting cases in the same old traditional way without coming to great outcomes for anybody. Not a good outcome for the defendant, not a good outcome for law enforcement, the police officer, not a good outcome for the prosecutor, not a good outcome for the community. And for whatever reason, maybe divinely inspired for all I know, that was what was on my mind that morning at 4 o'clock. On my mind that morning at 4 o'clock, and I patiently waited until I thought it was acceptable to call the state's attorney, and I called her at 6 o'clock in the morning, and she woke up, and I could tell I woke her up. And she said, "What's wrong? What's wrong?" And I said, "I've been up since 4 o'clock in the morning, and I've scribbled some notes here, but I think that the way that we're prosecuting drug crimes is completely wrong, and we need to totally revamp it." And she said, "Okay." And she wanted to make sure I wasn't on drugs. And she said, "Okay, I'm listening." And I said, "Okay, don't yell at me, but if you're going to yell at me, and don't hang up on me, but if you're going to choose one, hang up on me before you yell at me. But here goes." And I went on at least a 40-minute tirade about what I thought was wrong with the way that we did it. We represented, we're in Chicago, we're the second largest jurisdiction in the country, second only to Los Angeles. I told her what I thought was wrong about the way that we've historically done it and what I thought we should do differently. And at the end of it, I mean, she was very patient and silent. At the end of it, I thought maybe she hung up on me because there was silence on the other end of the line. And I said, "Are you still there? Did you hang up on me?" And she goes, "No, I'm just listening." And I said, "So what do you think?" And she said, "I think it's a great idea. Do it." And so there we embarked upon a radically different seismic change about the way that we looked at drug cases, where we, instead of favoring criminal penalties, which was sort of in the wheelhouse of the prosecutor, we started to rethink of this as a public health crisis, and we started to favor treatment over incarceration, for example. And so, without getting too deep in the weeds on this, we devised a new program where people that came into the criminal justice system, instead of getting a bond and being put in the jail at Cook County would tell you that the average daily cost of incarcerating a detainee in jail, a pretrial detainee in jail, is $143 a day per person per day. Now, I don't know, I'm not going to endorse that number because I've never really totally trusted it, but let's just say it's true. Let's even say it's less. That's an enormous amount when you apply that to the scale of a large justice system like Cook County. So, when I started back in the 90s, you'd see drug offenders come in, and they'd come in on their first day after they were arrested the night before, and then you'd see them again 3 weeks later at their preliminary hearing date, and now they spent 3 weeks in custody, 3 weeks at $143 a day, and then multiply that by thousands of people every year, and you start to realize the enormity of taxpayer resources that are being spent just in that sense. And it just seemed to me, and I didn't have the data, but it just seemed to me instinctually that we could make better use of that money if we favored treatment over incarceration. And so we embarked on our new path. And our new path, generally speaking, was that when an individual came into the criminal justice system, we, the prosecutor, would do something that's anathema to prosecutors. We would tell the judge that we wanted the person to get an I bond. If they came in, by the way, I need to say this very clearly, if they were a truly nonviolent, simple drug possessor. If they had violence in their background, it might be a different story. If there was violence involved with the particular commission of this crime and drugs were found on them incidentally, that would be a different story. But to the vast majority that came in, who were simple nonviolent drug possessors, instead of seeking some sort of detention bond or a detainer for them, we would ask the court as the prosecutor to issue them an I bond, and we would immediately put them in treatment with social service providers that I was happy to see gladly came on board with us, like Salvation Army, for example, that would give them treatment. And we weren't so naive to believe that trying this once would be effective. So our original model was that we'd give each one of these people 3 bites at the apple. That if they messed up, as often you might expect one to do, and they got arrested again and they were recidivist, that they could come back in and we would give them yet another bite at the apple and even a third. And maybe at this point it's even expanded beyond that. I no longer, by the way, I should have issued this disclaimer in the beginning, I no longer speak for the Cook County State's Attorney's Office because I'm no longer there, but I believe that they've continued in the spirit of this reform effort. And I'm glad to say that we saw amazing results when we did this. We saw a lot of people come in and go through treatment successfully and get out of that cycle. Because before, in the 90s, I would see these people come back week after week, month after month. You'd look at their rap sheet. It was just pages and pages and pages of PCS, 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 possession of controlled substance, possession of a controlled substance, shoplifting, other crimes that are incidental to feeding a drug addiction. And it just didn't make sense. And at the same time, there were other efforts that were being made legislatively and other places to address this opioid crisis. By way of example, Representative Kelly Cassidy, who's a state representative in the General Assembly, introduced a bill in Springfield whereby if Dr. Dickerson and I were engaged in taking heroin, for example, and I started to OD, he could call 911 and get me help without being in fear that he'd be arrested if he was found with drugs. It was almost a safe harbor thing. Because what we found were that a lot of people, if their friends started to OD on something, they wouldn't call them help. They'd just sort of run away out of fear that they'd be prosecuted themselves. We eliminated that. We created the drug diversion that I already spoke of. And we just started to look at this very differently. And this is, again, the changing role of the American prosecutor, looking at things differently and seeing it for what it is and trying to create better outcomes for all involved. Because you can imagine, by the way, every time a police officer has to have an encounter with an individual on the street, that can lead to all sorts of bad outcomes. It can be a violent encounter where somebody gets hurt, the police officer, the person being arrested, or somebody else. It can lead to civil suits later on. No good outcome. So our whole goal in doing all of this and in these efforts was to get people out of this cycle. I had another thought here. Part of what fed into this too, by the way, was the concept that unlike what you typically think of when you think of a criminal, somebody who holds you up at gunpoint, or somebody that murders somebody, or a sexual assault. Many people who entered into the criminal justice system at the entry point never intended on doing it. They entered into it through very innocent activity, going to a doctor and being prescribed something that was the first step. It would ultimately led years later into a severe addiction that led into drug crimes and other property type crimes, for example, and created this downward spiral. And because we recognized that it was so easy to become so innocently involved in the justice system from early on, we felt that it was quite just in the spirit of doing justice to take a radically different approach on the issue. So I don't want to go over my time, but I'll start with that, and I'm happy to answer questions as they come up.
So thank each of you for those introductory comments. Why don't we engage you with your questions, and I'll have each of the panelists maybe ask each other questions, and I'll throw in some there. But let's start with you. Any questions?
I was wondering about the opioid letters that you were sending out, if they were public record,
Yeah.
and if they were also the public, I mean, and if they were provided to insurance providers.
So the letters are not public record. Whether they would fall under FOIA, I'd have to ask our FOIA experts, but no, they won't be put on our website or anything. They're not a public report card similar to what we do for hospitals, for example. They are intended to be private communication, but could you FOIA your doctor's letter? I'm not sure.
No, but I mean, if I'm a mom taking my kid because he has a broken leg, do I want to go to the doctor who's ever prescribing opioids? I mean, really, isn't it a public health issue? We're looking at a pandemic.
Yeah, you're right. The extent to which we want to make that information public, unclear. The extent to which the public would know how to interpret that information properly, also unclear. You don't know if that physician happens to deal with more acutely ill patients, or et cetera, et cetera, et cetera. So I've got some skepticism around making it public. There's also obviously issues of some degree of issues of confidentiality there, but the real question is whether the information will be actionable. What was the question? The point about insurance companies, though?
Well, I mean, the same thing. You would assume that the data would be consistent if you're let's say a doctor that deals with, major trauma, that you're going to be higher and you're going to equate among your peers. I mean, it's still going to be a belt, right? Depending on your area of practice.
Exactly. In round 2 of the letters, we're hoping to narrow it by practice area. But right now, for the first iteration, the data just were not amenable to that. We're hoping in the future it will be. But with respect to the insurance companies, I will say I call them into my office pretty frequently to hear what they're doing and share data with them and that sort of thing. And in recent months, I have seen a high degree of interest and action from the private insurance companies as well. Especially on initiatives like this about informing doctors of their own data and such things. So, yeah.
So I think that just to kind of follow up on that, I actually love the spirit of that question, right? Because it's sort of like we're healthcare consumers, and who's protecting us? And I think that's a really good question for everyone that is a stakeholder, right? So a health system, a clinic, and I think the question could be rephrased into a very patient-centered question, which is, what are you guys doing about the opioid epidemic? Or how do you guys track how you guys prescribe opioids as a group collectively? And I think that more and more health systems at some of the new CMS, CMS has effectively mandated at the level of the Joint Commission new standards for how we track this. And so health systems are tracking this now. But those standards do not say, they're the spirit of the game. They don't tell you how you do it or how well you do it. However, when the Joint Commission comes and visits a facility, TJC, they are effectively going to have conversations about that process. And I think consumers should be able to have that process, have that question as well. It's led to stewardship processes at a lot of academic and community health systems. So having transitions recently from University of Chicago up to a private health system, it's really fascinating to see that this is all very iterative, but happening at a lot of places. And if it's not happening, I would be concerned as a consumer, because as we've dug into the data, as I, effectively pain stewardship at UChicago was this data-driven process that then led to the very comparison, the letters were what we were doing in terms of meeting for a cup of coffee with docs that were outliers. But until you look, you don't know. And a lot of places say, can we just not look? And so you want to know, is the place I'm taking my family member a place that looks? What do they know about their patterns? And I will tell you that everyone is held to a standard. How we're addressing that is different, and I think we're in the space where that's currently developing. But I do think from a consumer standpoint, I welcome that. In New Jersey, on the side of buses, it says, would you give your child heroin for their broken arm? I mean, so these signs have triggered a conversation now that physicians and their national societies are helping them prepare for. And so for that to be coming bi-directional, I think is the best approach.
Raul, can I ask a question of Dan? So,
course.
Dan, I'm encouraged by that whole change that you came up with about this idea of treatment over incarceration, because going back to what Dr. Shaw said at the beginning, part of the problem is the stigma attached to it, and making it more criminal is what starts that whole stigma. But having been the point person for the ADA on this issue, I've been running up against a lot of addiction specialists. And when you say the treatment, what they've been telling me is that, a couple of weeks or even 30 days of treatment isn't going to cure the problem. It's something that if you do that and you dump them right back out onto the street, you've essentially done nothing. So what kind of treatment is being envisioned?
So we didn't, we realized that we weren't doctors, and we weren't care coordinators, and that wasn't our area of expertise. And so what we did was rely upon our external partners that came in to help on the treatment side of it, to make that determination of what the appropriate treatment was for each individual. No two people are the same. Some need more treatment, some need less, but that wasn't a determination that we would make. What we did have control over is how long we would continue the case for. So if it became apparent to us that this is somebody who needs inpatient treatment, and it wasn't going to be a matter of a month or 2 months, but 6 months, we could easily continue the case for 6 months and see how the person did at that point in time before we disposed of the case one way or another. So we were very flexible on that point, because we had a recognition. As I said, we weren't naive enough to believe that one try was going to be successful. As a matter of fact, and maybe this sounds cynical, but I think it's realistic. I think that one try is not going to be successful with most people, and so we tried to create flexibility to make sure to enhance the greatest chance of success.
Great. Yes, ma'am.
Dr. Shaw, or, I'm sorry, is it Dr. Shaw or Mr. Shaw?
Just near, yeah.
Mr. Shaw mentioned
Yeah.
the PDMP. I practice law in West Virginia, and I do insurance defense litigation, but I come across a lot of personal injury plaintiffs who suffer from substance abuse issues. And as part of my practice, I commonly will get court orders for the Board of Pharmacy records. Our Board of Pharmacy is only one state, and I will oftentimes see people traveling as many as 8 hours
Yeah.
to get
Yep. That's a very good question. The idea of having rather than a state-by-state physician level or prescribing database, a nationalized one. There has been some discussion or movement toward that. It hasn't really accelerated much. It's challenging to do from an IT perspective. What has happened is states are simply sharing data with one another. So we here in Illinois have linked or merged our PMP with that of, I think, 8 states. I heard that maybe 9 now. And so if Dr. Dickerson logs on when he goes to his clinic this afternoon because he's looking at Joe Smith in the clinic, he can see whether Joe Smith has received OxyContin prescriptions, not just in Illinois, but from the pharmacies of 8 or 9 adjoining states. And that regional network has been a lot easier to accomplish rather than asking the federal government to institute or orchestrate a national level database. Interestingly, my counterpart in West Virginia has done a really great job of merging their PMP, not just with Virginia's and some of the adjoining and Kentucky's, but also with some of the states that are known where folks travel to, such as Florida. So those bilateral agreements are far easier than a coordinated 50. Well, there's actually one state that doesn't have a PMP yet. But so the 49 states getting together and doing a master agreement, boy, that's talk about herding cats. But bilateral ones seem to be a lot easier.
And we have been seeing the same thing, that there are states that share information. I mean, similar to if you have an iPass. Well, you can get through tolls all the way to the East Coast with your iPass. So there is an ability to have that kind of sharing of information, but it's not easy, and it is going to take some time. Dentists are very they complain about that quite a bit, because especially dentists who live on a border, maybe not only with one state but 2 states. Patients don't have to go 90 miles; they can go 5 miles, and just to have that artificial geographic border of a state be the end of the PMP doesn't make a lot of sense.
One major issue with the PMP as a provider is that methadone clinics do not currently report, and so that is a major factor from a fingerprint standpoint of who is my patient, what are their risk factors. The majority of patients are very forthcoming. However, if someone's receiving methadone, actively at a methadone clinic, I've had patients in my own clinic that ran the PMP, accepted their consult, and then when they got in the room, their chronic back pain was ... in the setting of methadone therapy. So had no idea that the patient, when we accepted the consultation, it wasn't even in the primary doctor's most recent notes in the referral. So I mean, with that, that's a major gap. And so it's these carve-outs that create some issues. And do providers understand where those carve-outs exist? That's really, again, where at a national level we're trying to create that, but it's also state by state. When we integrate the PMP into the electronic record, the integration process in most states loses the ability to look at partnering states. And so if you do have a patient if you work in a tri-state area like the north side or south side of Chicago, 2 places I worked, you typically are using the integrated part first, and if you don't see something, you then go to the PMP, and sure enough, you'll see their Indiana or Wisconsin reporting that's there. And so it gets a little bit convoluted. I've also seen issues where patients' names, some people go by their middle name and they're logged there.
Yeah.
So this is really where also we've been pushing through the Pain Care Coalition for a national identifier. You can imagine that the privacy advocates think that's crazy. Now we're going to give everyone a national unique identifier. We all have those already. We just don't want any more of them, I guess, is the idea. But this would be very helpful for being able to look at this from a care standpoint.
There was another question back here earlier. No? Okay, Miss.
Yes, thank you. I might take us in a bit of a different tack. So I'm an attorney mediator in Baltimore. And recently, about 3 years ago, one of my sons was catastrophically injured, which he's now quadriplegic, paralyzed from the neck on down. And it took us across the country, our first 6 months in 5 different ICUs, and then in that year thereafter into numerous hospitals because he was enormously complicated, 6'4", burst from C2 to C5,
Wow.
et cetera. And so I got interested in this opioid piece because I witnessed very well known and well regarded, and I am of the camp that would highly regard them. But there was such a use of the opioids, and we learned, even with our son, for every narcotic cocktail that the new place would want to give him, that 2 weeks on would be 30 to 45 days trying to wean off. And there was a constant battle that I had daily on rounds, trying to be involved in rounds to say, we don't want that. And I, at one point my son was 17, and then he turns 18 in the whole process, and it changed the game, and so forth and so on. So my questions really are, has there been any consideration in the opioid, you all being the experts in the opioid crisis and what is being done about it, anything other than the regulatory hammer, if you will, the list hammer, if you will, which I think are great, or anything else, that has considered two things. Integrative medicine, which is what I relied upon for our son, who's not been on any opioids now for a year plus, only because we got out of all those hospitals. And things like not just integrative medicine, but meditation and homeopathy and a lot of things that can be done, prayer, that piece. And secondly, as a transformative mediator, I was so struck by why there would be these constant prescriptions, and it occurred to me that the suffering of the physicians who have to be in these environments, and the nurses, day in and day out, witnessing people's suffering and pain, must be excruciating and enormous. And so I'm really curious if that is being included in any of the work afoot to curb the issue, in addition to what's already been discussed.
Thanks for sharing that story. That type of consultation is exactly sort of where the pain specialists fit in. And so, unfortunately, we disconnect that story and we go, well, those aren't my patients. Doctors do that. But they don't realize that that story has so many of the same themes as the patient that comes in with chronic knee pain that's on blood thinners and can't get a knee injection. Or there's so many parts of that are just common themes that we don't connect, right? So to answer the first part of your question, the push in the National Pain Strategy is effectively all pain care happens in a comprehensive format. So that way then when we're talking about lowest necessary dose of opioid, we're really talking about 0 for the majority of patients, because lowest, that superlative, is dependent on what are the other things we have at the table? How are we integrating? And so while I, as a comprehensive pain physician, can provide things like spinal cord stimulation, direct delivery of drug into the CSF at the level where someone might have a spinal cord injury or have a tumor, those are really advanced techniques that I still incorporate into acupuncture, mindfulness, cognitive behavioral therapy. The thing is, even at a place like University of Chicago or North Shore Health System, I am working with any and all resources I can identify for my network, because patients are diverse in terms of who they can see, who they can't see, and what their resources are. And so I'm drawing up a playbook wherever I am of people that I can bring in, and bringing that to patients like a menu. And that's sort of when I came to North Shore 5 weeks ago, the first thing I said was, what's the menu? What do we offer patients that have pain? How many pages are on that menu? And that's really important, because with options, the lowest necessary dose becomes a very different discussion in regards to opioids. And then it's and also what we're talking about is shared decision making. It's something that we're terrible at training in medical school, but we're gaining function there in terms of how we're incorporating that into doctor-patient relationship courses. So how would you like us to treat your family member? How would they like to be treated? Those questions are very open-ended, and they slow you down in clinic. But we're trying to find ways to make it so that that's how we're providing care. Your second part of your question really gets to the heart of the matter, and why I brought up those themes of people say those aren't my patients, or that prescribing pattern is not me. Those are all coping mechanisms in order to avoid what's really happening, which is this internalization of highly empathetic people of the very things that they're seeing every day. That makes them good at what they do, but it also, you're right, puts them at risk. And so when people talk about burnout, it's not because consultants have come in and said doctors need to see more patients. That's maybe a factor, but burnout probably comes from that. And we couple burnout with this discussion of resilience and pain training. I think the reason people are for lack of a better word, dumping their complex patients, is because it creates a sustainability issue for them and their practice. And that sustainability issue affects their sleep. It affects their mood. It affects how much joy they get from their job if they have to call security twice a day in their clinic. We call security probably 2 to 3 times in our clinic on the North Shore of Chicago, where you would say, gosh, that sounds like something you would see in, a very different care setting. These issues are everywhere. And part of that comes back to how do we as a system, nationally, locally, and even internally, as individuals, provide protection against burnout and resilience. And that's where I think some of these smart solutions in terms of stewardship, where we take on this burden and we develop tools rather than mandates. So we better equip our providers to be able to safely practice at the point of care and not disrupt their workflow. Make it so that they can be better, be safer, and also not make them feel like all of a sudden seeing the number of patients they're being asked to see is a burden on their well-being.
Yes, sir.
Thank you all for your time and skill and seriousness and humor. I do believe that the ABA puts out superior CLEs. This isn't an infomercial. This is a panel that's exemplary and a great example of giving some time and spending some efforts. My question would be to any one individual or the whole panel. Naloxone or Narcan, is this helpful substance? And for somebody who does not know, I'm a general practitioner along the border in southern Arizona, Pima County in particular. Our officers, our sheriff has decided it's too difficult for our very learned first responders to be able to safely carry this. They have no problem carrying their guns or otherwise. It is an epidemic that is scary, the analogy to HIV. Having seen that and lived through that, the stigma idea once upon a time of cancer, I thought was also very remarkable, because once upon a time, boy, you didn't talk about cancer. But what would you say to a sheriff that said, I can't be bothered with carrying Narcan or?
Well, let me take a stab at that. What would I say? I know what I would say because I did say it. I had this very conversation with, and I want to be careful how I say this because I don't want to throw any agency under the bus. But on the subject of Narcan, we were approached by then U.S. Senator Mark Kirk, who took great interest in this issue of the opioid epidemic and Narcan in particular. And he came to us and he said, do you think that we could increase the number of first responders that have Narcan available if they're the first ones on the scene? And I talked to a particular police agency, a large one in this jurisdiction, and I talked to them about equipping their officers with Narcan, and they weren't on board with it. And the response was that all fire department ambulances and paramedics are equipped with Narcan, and typically their response times are much shorter than the police response times, so they're going to get there first anyway, and they're the medical professionals who know how to administer it. I don't know that much about Narcan, but I do know that it's not difficult to administer. The whole point of Narcan is that anybody can administer it. It's administered nasally, or at least that's one of the methods of administering it, and it does have miraculous results and saves lives. And really what it came down to, I think, was that it was a liability issue. There was, a large agency that didn't want their police officer employees taking on additional liability because they were liability fatigued as it was, as police officers are increasingly becoming, just given the nature of their job.
I'm going to be even more cynical than my colleague. I too have had those discussions with various law enforcement officials in various different parts of the state. And what I would say to your sheriff in Pima County is, have him give me a call. That sentiment still exists, and I feel like there are many pretextual reasons that people offer that, when you really boil them down or strip away the onion, this is the cynical aspect, what they really get to is, we don't think those people should be saved. I mean, I think I really think that is what it is at base. They feel that these are individuals who chose that path. And I've had a law enforcement officer, an official downstate say, look, Nirav, we get it. You guys want us to save lives, but my guys are saving the same people's lives every month. The same lives. I've saved, in a southern county in Illinois, there's a guy that's been saved 7 times. So I understand the sentiment, but at root, I think the notion that they are espousing is not one of liability, to be candid, or one of cost or ease of access. I think it's, we don't want to help those people anymore. And that's sad. That is really sad. It's very reminiscent of the early days of the HIV crisis, when, it's stigma. And what I've told those individuals is, I get it. You might save somebody on Monday and then only to have to save them 2 weeks later. But if it were because not everyone is ready to go into treatment and help themselves the first time they overdose, or the second time they overdose, or the third time they overdose. But if it was your brother, and the day that he decided that this was the day he was going to change his life, I'd want him to be alive. And that's what Narcan does. So it's sad, but that's part of the stigma. So
as a
have him call me.
So as a follow-up to that, what do you see the medical world or the dental world working with substance use disorders or treatment courts and those kind of things? It seems that there's still some disconnect. What might be changing in the future?
Well, almost all multi-society guidelines endorse the role of naloxone. Just personally, I prescribe naloxone with we've developed criteria for pharmacists to dispense at University of Chicago without a prescription at the point of care when they're filling any opioid prescription. So they effectively, through the fine work that Dr. Shah and the department has done, effectively has made that possible, which is a very important change I think every state should undertake. Because it allows for pharmacists who are doctors to effectively dispense that without a communication even to the doctor. We have a courtesy communication. We've dispensed this. What's powerful about it is it's a moment for a brief motivational interview, which BMI's caught on with smoking cessation. The BMI that I have with naloxone oftentimes has patients reducing their opioid doses or stopping their benzodiazepines, because those are the main indications while I'm giving to people, or getting their other medical issues under better control. The fact that it's the only medication that they have at home, their opioids, that they need an injection or nasal spray for their family member to save their life, quickly gets the message across that this medicine is different. Don't play around with it. Store it differently. Dispose of it when you don't need it. And I dispense this actually for people that have acute pain, high doses of opioids after a surgery, that have comorbidities. My surgeons think I'm crazy when they consult me and I say, this person's going to get naloxone. And we have a meds to beds program at University of Chicago, which enables better adherence as well. So enabling that type of process where patients leave the hospitals after an issue, like an overdose, with the meds that they need, or leave the ER after an overdose with the meds that are going to effectively, hopefully, save their life the next time that happens. Because as Mr. Kirk alludes, this is a lifelong disease for many of these patients, like hypertension. It doesn't go away. And unfortunately, insurance companies, in terms of covering naloxone, in terms of covering some of the substance use treatment disorder medications, lock that in at about 6 months. Oh, well, you mean it's not gone away yet? This is a lifelong disease of the brain. Do we treat Parkinson's patients like this? They have a brain disease. We really need to shift the discussion towards chronic pain, opioid dependence being organic neurologic disorders. Would you treat Parkinson's patients like this is the real question.
So you had a question?
Yeah, I'm just curious, when you took this approach with the diversion to treatment, did you get any blowback from legislatures because what you're doing is you're changing the whole policy and the way the office works, or did you get more support from legislators saying that's great? And I know there's federal money for drug courts, and Illinois has them, but aside from whether they're constitutional or not, doesn't matter. But how does that work, sort of, with the politics of the state?
We got either support or silence from legislators. It's funny because, different elected officials they have different sensitivities or different drivers. Some are motivated by doing what's right from a social justice perspective. Some are motivated by the economic benefits that you can outline for them of decreased incarceration rates. I always found, and I still find, that when you speak to legislators or any elected official, you need to think of one of my favorite terms, which is WIFM, what's in it for me. And if you're going to talk to somebody who likes to be thought of as a budget hawk or a fiscal conservative, you're going to talk about the fiscal saving of decreased incarceration rates. And if you're going to talk to a social justice warrior, you're going to talk about it's just the right thing to do. But if you sort of design and tailor your message, you can get through to each one of them. So what's far more interesting is that as we embarked on this, I thought I was going to get a lot of pushback from police agencies and from police officers because in Cook County there are, I think this number is correct. I think we have 122 different municipalities. The Chicago Police Department's obviously the largest police agency in Cook County, but we also have all the suburbs too. And so one of the things I decided to do after I designed this program was to go on a road show and try to get buy-in. I wasn't sure whether I would or not. I'm happy to report that there was not one instance of any of the meetings that I had with police agencies where I ever got any pushback at all. None whatsoever. As a matter of fact, police officers, going back to the WIFM, what's in it for me, when you're talking to police officers about it, talk to them about, you're not going to have to see, Mr. X over and over and over and over again on these violent encounters, because hopefully the design of this is to get him out of this cycle. And that appealed to them. And believe it or not, and some people are cynical about this, but I know plenty of police officers who really do want to see a positive outcome for the people that they encounter on the street. Actually, I would say the majority of police officers that I've worked with wanted to see positive outcomes, as cynical as they may be due to the nature of their job.
Well, and also one other factor, I think there might also be, it might free up time instead of bringing in the low-level drug.
Sure.
Yeah, so you go deal with violent crime.
Sure. Sure. Any police officer out there would rather make an arrest of an armed robber than a nonviolent drug offender.
Question in the back, please.
Hi, my name's Cassandra. I'm from Australia.
Welcome.
From an international perspective, in the state where I'm from, we have a program called MERIT, and it's the Magistrates Early Referral Program into Treatment. And basically, people who are brought before the court with drug offences, if it's appropriate, they're given bail, and then they're referred into treatment programs. And there's a specific program. They get a one-on-one caseworker. They send them into different treatment programs before they're sentenced. They then come back before the court, and hopefully they're diverted out of the justice system. And what I'm seeing, I don't practice in this area, but I'm the president of the Regional Law Society, and I'm seeing that education is increasing. People aren't going straight for incarceration, and people are actually learning. And the people who are addicted to these substances are helping other people in the community, and it's really beneficial in regional areas where we just don't have the resources. If they have to go into incarceration, they have to go to a capital city, so they're 6 hours away from their family members and that sort of thing. So these sorts of programs are being rolled out across New South Wales and across Australia, and they're really working, and they're helping to get that education across the country. It's very interesting to compare the systems.
And you escaped your winter.
Pardon?
You escaped your
Oh,
winter.
it's
Yeah, you
beautiful,
picked
It's
a
not
good-
that cold, but it's
I know.
beautiful, yeah.
Well, thank you for joining us. I just wanted to make one small comment or amplification of that. Many of these programs started out as these so-called deflection programs, where someone is brought into the criminal justice system post-arrest, and then rather than following through with prosecution, moved into treatment. What many municipalities, counties in Illinois, across the country are now doing is avoiding the criminal justice system in the first instance. That is to say, if an individual who is grappling with substance use disorder, a heroin problem, pills, what have you, they are now empowered and allowed to walk into a police department and say, I need help. I don't want to get arrested, but get me help. Here are my drugs, get me help. And I'm actually really, really proud, despite my cynicism 3 minutes ago, that the second or third such program in the United States was actually rolled out in north central Illinois in a town called Dixon. The police chief there, a gentleman named Danny, you probably know Danny, was dealing with this problem over and over and over again, and he heard his counterpart from Gloucester, Massachusetts, at a conference roll out one of these so-called diversion programs, and he said, "Well, I'm just going to do it." And it's been a resounding success in Central Illinois, where folks can walk into the police department and say, these are my drugs, these are my paraphernalia, get me help. And for the first several months of the program, Chief Langloss himself was driving these individuals to treatment centers in his car. And so that's the sort of an extension to what we initially saw, and it's quite promising, and I couldn't be more excited about those programs.
This idea also, tying together two of the themes that you've heard today about the diversion into treatment and naloxone, they're very tied together, because if you are able to save this person's life and get them into treatment, often that is the person, maybe not the first time or second time or third time, that actually ends up helping others with their addiction. They end up as part of the diversion treatment. And so, it's the point can definitely be made that it's worth saving those lives.
Can I just add one other point too? I think that this highlights a very important point, which is that you need to employ a multifaceted approach. What Dr. Shaw just pointed out that they're doing in Dixon, Illinois, I applaud them, because I think that's the right thing to do. We had a prosecution-run program. There are court-run programs. No two individuals are the same. There are some individuals that need proper motivation to comply. That's a nice way of putting it. But there are some individuals that need the 10,000-pound weight hanging over their head before they finally see the light and have a breakthrough. I've seen that work with people. There are people that don't need that level of motivation. And so you need to really think of a multifaceted approach to achieve the best outcome across the board.
We have time maybe for one last question, sir?
Doesn't that assume that you have unlimited treatment opportunities? Because where I'm from, waiting lists,
And funding.
What do you do with a defendant who wants needs treatment, but there's no place to go?
Well, so I think that speaks to the issue of how are we spending our resources. If you buy into the number that I threw out earlier, the $143 a day, that's a whole lot more expensive than it is to treat somebody once or twice, rather than seeing them come back into the system for 10 years over time and spend weeks and weeks without producing any positive outcome for anybody. So I think that if the conversation hasn't begun in your jurisdiction about wise use of resources, it ought to, because everybody's facing, everybody in Illinois, everybody across the country are facing similar problems of budget constraints. And so the conversation about the wise use of resources is more important now probably than it's ever been.
Yeah, thankfully, Illinois is flush with cash.
Yeah.
So that hasn't been an issue for us. But even despite that, just the wealth of riches that we have in our state coffers, treatment is still a challenge. Availability is still a challenge. Some of it is due to structural reasons. Rural areas, very spread out. Some of it is just having the physicians who are trained in providing that. So there are a number of challenges. It has become one of the top priorities of our agency to expand treatment. Not long ago, the federal government issued about $47 million to Illinois, and we're using about 46.8 of it to expand treatment access. So that's a top priority of ours.
Any last comments from any of our panelists? Any last questions? So would you please join me in thanking our panelists?